welcome you all to this 15th series in the Amrita E-Gurukul. And the topic for today is drugs in myeloid neoplasms. And for today, our program director is Dr. Vidit Kapoor. Dr. Vidit Kapoor is an assistant professor of medical oncology at Amrita Institute of Medical Sciences, Faridabad. And he will take you over. Thank you.
Thank you, Karan, and it's been a pleasure being involved in this E-Gurukul series and serving as the program director. So I welcome you all again today for this 15th session in the E-Gurukul series, which is an online educational initiative that fosters learning among students, fellows, and medical oncologists. So today's session, we will focus mainly on drugs used in myeloid neoplasms, and hopefully we will dive a little deeper into the mechanisms of actions, the utility, the utilization, and the side effect profile of these drugs. And to guide us through this important discussion, we have with us Dr. Stalin Bala, who is a renowned medical oncologist. He currently serves as the chief medical oncologist, hemato-oncologist, and BMT physician at Mahatma Gandhi Cancer Hospital and Research Institute in Vishakhapatnam. So without wasting any time, I would like to request Dr. Stalin to take stage and moderate the session. Thank you so much, and I hope you all have a wonderful session. Thank you.
Yeah, good afternoon to all. Thank you, Dr. Karan, and thank you, Dr. Vidit. So, uh, so without much waste of time, already we are 5 minutes past 2. So we'll move into the topic proper. So the mentor for today is Dr. Faheema Hasan. She is Associate Professor, Department of Hematology, United Institute of Medical Sciences at Prayagraj. So today we have a presentation by Dr. Ramesh. So who is a consultant hematologist and BMT physician at Vellamal Medical College and Hospital, Madurai. So he will initially take us through what are the various drugs in the myeloid neoplasms and their mechanism of actions and the side effect profile. So after that, we'll have the Viva session. So over to Dr. Ramesh.
A very good afternoon to one and all. So thanks, Dr. Stalin sir. So thanks, E-Gurukul, for giving me this opportunity, and thanks, special thanks to Dr. Faheema Hasan. So let me share my screen. I hope my screen is visible.
Yes, visible.
So we'll start with the drugs in myeloid neoplasms. So we'll be covering the drugs used in AML, acute myeloid leukemia, and myelodysplastic syndrome, and what are the drugs used in MDS bar MPN, myelodysplastic syndrome bar myeloproliferative neoplasm, overlap syndromes, as well as in MPNs. First is myelodysplastic syndrome. So in MDS, we have low risk MDS as well as high risk MDS. In low risk MDS, generally, like the treatment is erythropoietin, or you have lenalidomide. So next in the treatment pipeline is we have this drug luspatercept. So this drug basically, if you see, look at the structure of this drug. This has got two domains. So one is the domain is the FC domain of the IgG antibody is present, and top of it you have the domain which traps the activin receptors of the TGF beta superfamily. So it basically traps the TGF beta ligand and inhibits it, so that the inhibitory signal is blocked, and it helps in the production of RBCs. Unlike the erythropoietin, which acts in the early erythropoiesis, this acts in the later point of erythropoiesis. As you can see, this inhibits promotes the proliferation from the polychromatophilic erythroblast. And the dosage dosage for this drug is 1 milligram per kg subcutaneous once in 3 weeks, and you can titrate it up to maximum of 1.75 mg per kg. And it is approved for low risk MDS with SF3B1 mutation, and also in MDS with ring sideroblast, and also in MDS bar MPN with SF3B1 mutation and thrombocytosis. So moving to the next drug in MDS, we have decitabine plus cedazuridine. So this combination is an oral combination which is approved in high risk MDS as well as in CMML, chronic myelomonocytic leukemia. So this decitabine is a hypermethylating agent. So, like other hypomethylating agent is the azacitidine. If you see the CC486 is the oral azacitidine. So, if we could see all the hypomethylating agents, these are nothing but these are analogs of the pyrimidine. So this goes and binds to the DNA and at the specifically at the during synthesis phase, and it inhibits the DNA methyl transferase, and thus it causes hypomethylation. And this is metabolized by cytidine deaminase, because of which the bioavailability is poor. To circumvent this bioavailability, we to decitabine they have added this sedazuridine, which is a cytidine deaminase inhibitor. So this combination is decitabine 35 milligrams with sedazuridine 100 milligram. So bioavailability is good because of inhibiting the certain deaminase. It's given 100 milligram once daily from day 1 to 5 of a 28-day cycle. So azacitidine mechanism we have discussed. It's a pyrimidine nucleoside analog of cytidine which inhibits the DNA methyl transferase. And the dosage is 75 milligram per meter square per day for 7 days in a 28-day cycle. It can give it as IV or subcutaneous. Indication is in AML with less fit individuals. It is given along with venetoclax. And in MDS high risk, it is approved. And the complication is mainly it causes myelosuppression. Coming to the next one is the oral azacitidine. This is not actually bioequivalent of the injectable, so it cannot be like alternatively used. This approval has been obtained. It has been approved in AML patients in who have achieved a complete response following an intensive chemotherapy, like for example a 7+3 or a FLAG-IDA. The patient is going into complete remission, but they are not able to proceed for the further intensive therapy, like consolidation with either high dose Araci, or they cannot be taken for a transplant. In such a cases, we can give this oral azacitidine as a maintenance. Like the dosage is 300 milligrams once daily from day 1 to 14 of a 28-day treatment cycle. So the main complication problem with the patient faces is gastritis. So this is the trial. Here they have come with the placebo. It was randomized control, and you could see very well the median oral survival is improved, and the relapse-free survival is also better with this oral as a maintenance. So moving to the next one is the 7+3 induction. So the main and in the 7 is the cytarabine. The cytarabine, this the dosage, when you see the dosage of cytarabine, you can use either 100 milligram per meter square, or there is also studies showing 200 milligram per meter square. It's given as IV continuous infusion for 7 days. So both are shown to be equally efficacious. So 100 milligram per meter square can also be used. So coming to the days, how many days to use, like 5 days or 7 days or 10 days, there is no consensus. Like everything has shown better responses. But ideally, it should be the higher doses of cytarabine, because that causes a higher remission rates and superior relapse-free survival and long-term benefit in oral survival. So this drug is also used in consolidation, cytarabine. So the cytarabine, what is the dosage we have to use and how many cycles we have to use? So this is there are so many studies I have quoted here showing you could very well see the the forest plot showing a 3 gram is better in a favorable and adverse group. Intermediate slightly it is favoring, but overall if you see it is the dosage is 3 gram per 3 gram per meter square should be the proper dose for a better survival of the patient. And here is the cumulative relapse-free survival is also better with 3 gram. The complications faced is chemical conjunctivitis because of this drug, and it also can cause cerebellar toxicity. So daunorubicin is anthracycline. So what dosage we have to use and which one to use? So 60 milligram or 90 or 45 milligram per meter square. So there are many randomized control trials. So if you compare 90 and 45, so 90 has shown superior results. So definitely, and 60 milligram is equally effective as 90. So it's better we use 60 milligram per meter square, so the toxicity is lesser. And the benefit of 90 milligram is it is daisy. It's different in different studies. And any anthracycline can be used, like not necessarily dono. You can use edarubicin or metazentron also, but take into consideration the cardiotoxicity and the cumulative dosage and how the conversion has to be made. So this is a table showing the conversion factor of doxa, dono, epirubicin, EDA, and metazentron, and the cumulative toxicity of the drug. So next drug can be used in induction is the fludarabine. So this is an anti-metabolic, it's a purine analog. So it has got a synergistic action with other drugs, cytarabine. So higher systemic fludarabine concentrations might yield high intracellular concentrations of this triphosphorylated compound of fludarabine and cytarabine. So the dosage is 30 milligram per meter square per day for 5 days in combination with cytarabine plus without idarubicin or GCSF, that is flag IDA. That combination is flag IDA plus GCSF, and complications are it causes severe bone marrow suppression and it can cause transfusion associated GVHD. So to prevent that, you have to use irradiated blood products only if you are using this drug, and it can also cause hemolytic anemia. So what are the intense chemotherapy regimens other than 7+3? We have flag IDA. Venetoclax can be added to all the intensive regimens. Otherwise, it can also be used singly without venetoclax also. So flag IDA you can use fludarabine. We have discussed here 30 milligram per meter square from day 2 to 6, and cytarabine 1.5 gram per meter square day 2 to 6, and idarubicin 8 milligram per meter square or day 4 to 5. And CLIA, you have CLIA plus venetoclax. It has shown very good results. Fludarabine is used instead of fludarabine from day 1 to 5 milligram per meter square, along with cytarabine and idarubicin. And you can also cut short the 7+3 into 5+2, and you can add on venetoclax. And you can also use CPX351 along with venetoclax. We'll discuss it later, CPX351, what it is. So the magic drug in AML, I could say, is the venetoclax. How the breakthrough in CML came with the introduction of the imatinib. Similarly, venetoclax is a breakthrough in AML patients. So what it does is, so this is a picture showing the apoptosis extrinsic pathway. So here, once the death receptor is bound with the ligand, so it activates the caspase, and the caspase, pro-caspase converted to caspase, and it is sensed by the apoptosis sensors bit, and it activates the channel, back channel in the mitochondria inner membrane. So this channel is opened and cytochrome C is released into the cytoplasm, and it causes apoptosis of the cell. This is basically inhibited by the BCL2, BCLXL, and MCL1. These are all anti-apoptotic. So if you'll be inhibiting these anti-apoptotic molecules, there will be apoptosis of the tumor cell. So that is what venetoclax does. So it inhibits the BCL2. So azacitidine, if you see, it acts very well with venetoclax because it has got a potential to inhibit the MCL1 and BCLXL. So it deprives the cell of it makes the cell to be dependent only on BCL2 for its survival. So if you add venetoclax along with this, so it causes very good effects. So these are the treatment options for AML patients who are not eligible for intensive chemotherapy. So the preferred one is azaven or decitabine venetoclax also. Or other recommended can be low dose Arasi along with venetoclax, or single monotherapy as a decitabine, or glass degib plus low dose Arasi, or gemtosima posagamycin in CD33 positive AML, or best supportive care. So this is a while A trial which showed the benefit of Ven-Aza combination over Aza monotherapy. So the survival, 2-year oral survival is very much better with the combination than monotherapy. The hazard risk is less than 1. So how do we adjust the dosage of venetoclax if you're going to give an antifungal prophylaxis with azole? With azoles, mostly we'll be using a mold coverage prophylaxis. So most of us are using the posaconazole as the antifungal prophylaxis in AML patients undergoing induction therapy. So how much we are supposed to use ideally is, so the standard dosage is the venetoclax is a 400 milligram we are supposed to give. But if you're using along with posaconazole, what they recommend is this is one article which shows the recommendation for posaconazole. If you're along with posaconazole or voriconazole, if you're using, you have to give just 50 or to 70 milligram of venetoclax. That is sufficient. That is what they have advocated. But practically we use 100 milligrams. Or if you're using isovoconazole, like isovoconazole being a moderate inhibitor of CYP3A4, you can use up to less than 200 milligrams. So this is what is recommended. And 600 milligrams of venetoclax is approved for 5+2 plus regimen of plus venetoclax we have discussed previously, or low-dose Arasi. The dosage is 600 milligrams, unlike the routine combination of azavan, where we use 400 milligrams of venetoclax. So this is actually the double advantage. You're adding a azole, so it cuts down the cost of the venetoclax also. But what are the complications of venetoclax? Causes severe neutropenia and thrombocytopenia. Main cytopenias are the main problem with venetoclax. There is also a risk of tumor lysis in AML with venetoclax. So step up dosage as per recommendation is day 1 is 100 milligrams, and day 2 we have increased to 200 milligrams, and day 3 onwards it is a full dose, that is 400 milligrams. But tumor lysis is not very severe. Only very few cases they do have tumor lysis with AML, unlike CLL, where it is a very dreaded complication with venetoclax. Moving on to the next, we have the IDH inhibitors. In relapsed refractory AML, it is approved. IDH1 is ivosidenib. IDH1 inhibitor is ivosidenib. The dosage is 500 milligrams once daily, and IDH2 inhibitor is enacidenib. It's 100 milligram once daily. So what is the mechanism is, basically IDH is important in the, it's an important enzyme in the Krebs cycle, TCA cycle. So it causes the 2-oxyglutarate formation. So because of this mutation, it causes a 2-hydroxyglutarate, which is an oncometabolite. So it basically inhibits the formation of the oncometabolite. So the side effects observed are neutropenia, or it can cause differentiation syndrome. So moving to the next target agent, it's a FLT3 inhibitor, FLT3 ITD or TKD inhibitor. So the first picture on the left is the FLT3 receptor. We have the, if you see, there is a transmembrane domain, external domain, and there's a inner domain. Inner domain, we have the tyrosine kinase domain and juxtamembrane domain, and that is the inactive conformation. So when it is dimerized, that is the active conformation. So type 1 inhibitors, they basically inhibit both ITD as well as the TKD. TKD is one mutation is one which is you can see in the active conformation inside, and ITD is at the just above the juxtamembrane domain. So type 1 inhibitors inhibits both ITD as well as the TKD. So type 1 inhibitors are midostaurin, crilotinib, and gilteritinib, sunitinib. And type 2 inhibitors, they inhibit only FLT3 ITD. So that includes the sorafenib, quizartinib, ponatinib. So to sum up, it is in FLT3, first generation type 1 inhibitor is midostaurin, and type 2 is sorafenib, because it targets other kinases also. First generation, like KIT, PDGFR are also inhibited to a certain extent. Whereas the second generation FLT3 inhibitors, they are more specific, more potent, and they do not have much off-target effects. And type 1 inhibitor among the second generation is gilteritinib, and type 2 among second generation is quizartinib. Type 1 is effective in both ITD and TKD, type 2 only in ITD. So midostaurin is approved in newly diagnosed AML. So the caution is, when you are using with a CYP3A4 inhibitor, it can cause prolonged QT. And gilteritinib, it's used in relapsed refractory AML. It is approved. It can cause differentiation syndrome also. So electrolyte imbalance is a problem with this drug. It can cause hypokalemia, hypomagnesemia, so that leads to QT prolongation. Next in the pipeline, we have revumenib, which is approved, which is a KMT2A inhibitor for MLL rearrangement. It's a menin inhibitor. It is approved for relapsed refractory KMT2A mutated AML more than 1 year of age, and the dosage is 270 milligrams twice daily. And the warnings are differentiation syndrome, QT prolongation, and allergy. Next, we have the CPX351. This is a fixed combination of 5:1 molar combination of liposomal, cytarabine, and daunorubicin. So here daunorubicin is 44 milligram per meter square, and cytarabine is 100 milligram per meter square liposomal given on days 1, 3, and 5. So this leads to longer median overall survival and a higher 5-year survival rate compared to 7+3 in patients of therapy-related AML or AML with MDS-related changes. Next, we have gemtuzumab vasogamicin, which is the anti-CD33 molecule. So this is with the payload, like similarly like inotuzumab. So this has shown overall survival benefit in patients of core binding factor leukemia, core binding factor, that is translocation 821, inversion 16 AMLs. and patients with AML with NPM1 mutation. The problem with a risk factor with this is risk of veno-occlusive disease. So this drug is used in the AML patient, and if they relapse within a short period of time, you have to take up for a transplant. You have to planning for a myeloablative conditioning. Be very cautious of VOD, that is sinusoidal obstruction syndrome or veno-occlusive disease. Glasdegib, this is a sonic hedgehog inhibitor, inhibits the hedgehog pathway. So the dosage is 100 milligram once daily. In elderly AML, unfit AML, it can be used along with venetoclax. The problem is cytopenia and QT prolongation. So next we are moving to acute promyelocytic leukemia. So here two drugs are used. One is ATRA, all-trans retinoic acid. Next is ATO, arsenic trioxide. So the problem here, the mechanism of action is basically both are differentiating agents. So what happens in APML is the PML RARA gets fused. Because of that, the nuclear bodies are disrupted. So nuclear body actually is needed for the differentiation of the promyelocyte into the mature cells. So when this disruption occurs because of this fusion and the fusion transcript, so this drugs goes and binds to the fusion protein, and it further causes the reformation of the nuclear bodies, and it further attracts the co-activators and causes a transcription reactivation, leading to the differentiation of the promyelocytes into the other cells. So since both are differentiating agents, the problem is differentiation syndrome is the problem, and once they differentiate, they can have hyperleukocytosis and leukostasis. All these can be the problems with both, and ATRA specifically causes a pseudotumor cerebri. So this is a differentiation block which is relieved by this ATO ATRA. So the mutant protein is proteasomally degraded, and it causes a granulocytic differentiation because of the nuclear bodies activation. So sometimes there can be mutations in PML or in the RARA component. So that can cause the patient refractory to ATO. Sometimes they do not respond to ATRA because of these associated mutations. This is a busy slide showing the algorithm for APML. So the dosage for ATRA will be 45 milligram per meter square per day in 2 divided doses given throughout the induction, and it's also used in consolidation as well as the starting phase of maintenance. So if the patient has got a pseudotumor cerebri, the dosage you have to cut down to 25 milligram per meter square, and arsenic trioxide, the dosage is 0.1 mg per kg, maximum of 10 milligrams. So this is a overall flow chart for the targeted agents used in AML. So we've almost discussed all. I'll be concentrating on a few. First, KIT inhibition. So you can use dasatinib, especially in patients with 821 translocated AML. So a few patients, they have KIT mutations. So that can be used. And a CD123 inhibitor, tagrasafas, and CD47 inhibitor is a magrolimab. So it's a do not eat me signal. So that can be inhibited and by the magrolimab, or TIM3 inhibitor sabatolimab. There are also upcoming CAR-T for AMLs, and rest all we have discussed. Selinexor can also be used exportin 1 inhibitor. So a few words on AML transplant regimen. What are the medicines used? The conditioning regimen for a fit individual AML with the standard with the intermediate risk or a high risk or at relapse, we are supposed to use the we have to take up the patient for transplant, and in the conditioning, it should ideally should be a myeloablative conditioning. So these are the various agents which are used in the myeloablative conditioning regimen. It can be fludarabine and busulfan for 4 days, or you can add on ATG along with that, or fludarabine along with melphalan. That will be a reduced intensity conditioning. Fludarabine along with melphalan conditioning, that is it's not a myeloablative, slightly lesser than that, but not like a non-myeloablative. So it is a reduced intensity. It results in longer survival of the patients. So tox is slightly lesser, and the response are also similar to TB-based conditioning. The dosage is fludarabine 25 to 30 milligram per meter square for 4 to 5 days, or with melphalan 100 milligram per meter square is used for patients who are transplanted in CR, the first CR1, or higher dose of melphalan for those who are having an advanced disease. So melphalan, as you all know, it's alkylating agent. The complication main problem is mucositis. So moving away from AML, so we are entering into MPNs, but hydroxyurea, this is a cytoreducting agent used both in AML as well as MPN, basically used for cytoreduction. The dosage can be 50 to 100 milligrams per kg per day, and main adverse effect is a bone marrow suppression. And they can also have leg ulcers in MPNs for on hydroxyurea for longer time. So this nail discoloration or the palms and sole discoloration and sometimes tongue discoloration also seen with the hydroxyurea patients who are taking it for a long time. Into chronic myeloid leukemia. So these are the tyrosine kinase inhibitors approved and used in CML. First generation is imatinib. So the common side effects can be fluid retention, weight gain, and sometimes the muscle body ache can be the complaint. Few patients, they can have diarrhea and skin depigmentation can be there. And the toxicity we have to look is a renal toxicity. So the dosage is 400 milligram once daily. The lowest range can be used is 100 to 200 milligram per day. Nilotinib is the second generation. The dosage is 300 milligram once daily, or in CP patients or who are having accelerated blast crisis, it is 400 milligram once daily. So main common side effects are it causes impaired glycemic control and dyslipidemia. This is the main problem, and because of this, the patients can have the thrombotic episodes. So it can the toxicity we have to watch for is worsening of diabetes and pancreatitis. So prohibitive toxicity is a arteriocclusive vaso-occlusive event. So dasatinib, it's again second generation TKA, can cause pleural effusion or cytopenia. The toxicity you have to look for is the pulmonary hypertension. And the patient has got more than one episode pleural effusion or pulmonary hypertension, you have to stop this drug. And bosutinib, the dosage is 400 milligram once daily in CP patient, and in advanced disease, you have 500 milligram once daily. Main problem side effect the patient faces diarrhea, and it can also cause renal or liver dysfunction. So the prohibited toxicity is enterocolitis. The ponatinib is for use for patients of T315I mutation. So it can cause hypertension or pancreatitis. The main most important dreaded complication of this is arteriocclusive or vaso-occlusive events, and can cause refractory hypertension also. The dosage is 15 milligrams per day, can go up to 45 milligrams per day in advanced disease or blast crisis. Next on the new kid on the block in CML is asciminib. So this is not a tyrosine kinase inhibitor. This is a non-tyrosine kinase, a STAMP inhibitor. So what is it? Is it basically mechanism of action is different than the TKAs. So this goes and binds to the myristoyl pocket of the ABL1, and it causes it to be in the inactive conformation, so that the protein mutant protein formation is reduced. So this is approved in T315 mutated CML. The dosage is 200 milligram twice daily, and in newly diagnosed CML, it will be 80 milligram once daily. The main adverse effects are bone marrow suppression, cardiovascular toxicity, pancreatitis, and hypertension. So move to polycythemia vera. It's rho-peg interferon alpha. This is a monopegylated interferon formulation dosed every fortnightly, and the dosage is 100 microgram once in 2 weeks. So you can increase the dose by 50 microgram every 2 weeks to maximum 500 micrograms in polycythemia. This is the only drug in polycythemia which causes the reduction in the allele frequency of JAK2 V617F. The main side effects are cytopenia, liver dysfunction, mood or neurocognitive effects. So myelofibrosis is a ruxolitinib, is a JAK1/2 inhibitor. The dosage is 20 milligram twice daily, or you can taper down to 5 milligram twice daily if the patient has got a thrombocytopenia. So main problem or concern with this is the cytopenia or tuberculosis reactivation. Other JAK inhibitors use myelofibrosis or pacritinib. This is a JAK2 activin receptor 1 inhibitor. So this indicates in patients with myelofibrosis having thrombocytopenia. Side effects is QT prolongation or diarrhea. And fedratinib, it's approved in JAK2 MF with anemia. It's a JAK2 and FLT3 inhibitor. The black box warning for this is Wernicke's encephalopathy. And momelotinib, this is a JAK1/2 activin receptor 1 inhibitor, and it causes cytopenia, infections, and hepatotoxicity. So these are numerous novel agents used in myelofibrosis. I heard from Dr. Karan that you had a separate class on myelofibrosis, and I'm not going into the detail of it. So just to have a recap of it. So BET, you have BET inhibitors, pelabresib, and TERT inhibitors, imetelstat. These are used, and exportin 1, selinexor, and navitoclax, the BCL2 as well as BCL-XL inhibitor, and PA3K inhibitor, parsalinib, and you have tasquinimod, that's a TLR4 inhibitor, and you have active receptor inhibitor. Luspatercept is also being used here. So my last one is the blastic plasmacytoid dendritic cell neoplasm. So this one, it mostly they have cutaneous presentation. So they present with maculopapular rashes and all. So this is a aggressive disease. So here the medicine used is a tagrosta first. This is CD123 inhibitor, and the black box warning for this is capillary leak syndrome. So thank you for all for the patient listening. I thank once again the E-Gurukul Amrita group for giving me this opportunity. Special thanks to Dr. Faheema Hasan, and I thank Dr. Karan for coordinating very well, and special thanks to Dr. Prashant Mehta sir. Thank you all.
Yeah, thank you. Thank you, Dr. Ramesh, for that very lucid talk on the drugs in myeloid neoplasms. So for all the residents here, so Dr. Ramesh has nicely elucidated various drugs which were used in the myeloid neoplasms. So for coming to the myeloid neoplasms, so we have only broadly dividing. So you divide them into either AML, acute myeloid leukemia, chronic myeloid leukemia, or some cases you may be seeing the myelodysplastic syndrome. So broadly, so myeloid neoplasms you see in your clinic and in day-to-day life are the acute myeloid leukemia and the chronic myeloid leukemia. For acute myeloid leukemia, you put the algorithm simple. The two common drugs we have been using since almost 4 to 5 decades are the donomycin and the cytarabine. You can replace the anthracycline with idarubicin. So in place of the dono, you can use an idarubicin. So other anthracyclines are also used either in the upfront or in the relapse setting. Like another anthracycline which was used is the mitoxantrone. So the common anthracycline we use is the donomycin because of the cost issues or widely availability in India where many of the patients can afford. So to that backbone, various other agents have been added in the last 4 to 5 years, like the FLT3 inhibitors. So the two FLT3 inhibitors which are available in India right now are the midostaurin, which was used in the frontline management of newly diagnosed AML. The second thing was the chilteritinib. We usually use it in a case of relapsed refractory AML, which is FLT3 positive. Second thing is the IDH inhibitors which were added. And the third component is the gemtuzumab oxazomycin. So it is used and it has been shown good effect only in the core binding factor, that is a favorable risk AML. So these are the broadly the drugs which we use for the relapse setting. So we have different regimens. The common regimens we use are the FLAG and CLAG regimens. For an elderly elderly AML patient who is unfit to receive an intensive induction. So we moved completely away to azacitidine venetoclax across many centers. So this either you use a single agent hypomethylating agent, either decitabine or azacitidine, or you can combine it with venetoclax. Uh, Even FLT3 AML, you can add some FLT3 inhibitor to that also. But by and large, so azacitidine venetoclax has become the standard of care for elderly unfit individual who is unable to receive an intensive induction chemotherapy. So he has nicely elucidated the azacitidine, decitabine mechanism of actions and everything. And venetoclax also the drug combinations. So how the drug dosages and how we modify. So traditionally it is used in a ramp up phase of 100, 200 and 400, but across all centers in India, so majority of the physicians practice it the 100 mg fixed dose of venetoclax because we all give it with a strong CYP3A4 inhibitor like posaconazole in our day-to-day practice. So previously the 50 mg, 10 mg formulations were not used because many centers have used a generic formulation of venetoclax, but now the original venetoclax was available and it is available in 10 mg and 50 mg formulations also. If lower doses need to be used, we can comfortably use the lower doses of venetoclax too. So coming to the CML, so imatinib is the gold standard drug. So the first generation BCR-ABL tyrosine kinase inhibitor. So it has proved its efficacy almost, and it is in the treatment of CML almost for a period of 2.5 decades, way back from 2000 to 2025, and it still holds good in the frontline management of CML in chronic phase. Later, over a period of time, the nilotinib, dasatinib has developed, and recently with the concept of TFR, that is the treatment-free remission, and we are now talking about cure in CML where we can stop the drugs. So with the newer drugs, the dasatinib and nilotinib, we can achieve a faster remission rates and a deeper remission rate, so that we can use a shorter period of tyrosine kinase inhibitor and we can stop the drug for a period of time, and in 50% of the patients you can achieve the TFR. So what is the beauty of the second generation tyrosine kinase inhibitors like dasatinib and nilotinib over the first generation is you can achieve a faster response rates, you can a deeper response rate, so that you can plan a treatment-free remission. Otherwise, as of now, so there is no much overall survival difference between the first generation and second generation tyrosine kinase inhibitors. Third generation ponatinib is not available, but it is very effective in the management of T315 mutated CML, and also the CML which is refractory to the first and second generation, you can use ponatinib. The initial approved dose of 45 mg is not being widely used because of the arterial occlusive event. So we either use a lower dose of 15 mg, but standard dose we start is 30 mg. Once the response is there, you can cut down the dose to 15 mg to reduce the toxicity. Asciminib, so this is completely a different tyrosine kinase inhibitor than the BCR-ABL tyrosine kinase inhibitors because it acts at a different site, and this is irrespective of the mutation, it will work. So initially the data was in T315 and in the resistant CML. Now slowly in the front line we have a data with asciminib. But we generally don't prefer because of the cost issues or everything, and because we have much experience with the imatinib. So we generally not, as of today, not using them in the frontline CML. We generally reserve it to a resistant or especially the T3Y15 mutated CML. Coming to the MDS, so he has nicely discussed the destabin and destabin plus cedazuridine combination. So one thing was specific to the myelodysplastic syndromes was the, especially when the myelodysplastic syndrome patient is worked up and they has a 5q deletion. So the drug of choice there will be the lenalidomide. So where lenalidomide has shown to have significantly reduced the transfusion dependence in the MDS with 5q deletion. So apart from the hypomethylating agents, lenalidomide, and in low risk MDS, especially where the patient has only anemia, erythropoietin is also being used, and luspatercept, he has nicely elucidated the mechanism of action and the dosages. So this is regarding the drugs in myeloid, to a brief gist of various drugs in the myeloid neoplasms. Next, we will move on to the Viva and the expert comments. So for the today's Viva and expert comments, we have two eminent personalities in the hematological oncology. So Dr. Menon sir. So sir is professor hematology and head at medical oncology at St. John's National Academy of Health Sciences, Bangalore. So welcome Menon sir. And another is Dr. Prashant, who is senior consultant hemato-oncologist and bone marrow transplant physician at AIIMS Faridabad. So today's examinees are the Rohan Jacob Verghese, so who is senior resident at Department of Medical Oncology, Tata Memorial Hospital, Mumbai, and Dr. Aishwarya Ghule. So she is DRNB resident, medical oncology resident, third year from Pune. Sir,
Thank you.
Sir.
Yeah. Thank you, Stalin, and thank you to the Amrita Gurukul for a novel concept and a very important aspect of the teaching program. Because for me, if you are not aware of the way that you are treating a particular condition, then you are not. It's not valid for you to be treating the patient, because you are giving toxic medications and you need to know how the mechanism works and where to implement those treatments, and in what way to identify toxicities earlier so that you don't create damage. So with that, I would hand it to Prashant for his comments. Yeah.
Thank you so much, sir. I am still in my car.
Yeah.
I'll reach home in a while, but I'll just with the disturbance on. So
Yeah.
thank you for being here, and you have been our mentor for a long time now, and we look up to you. Thank you for joining the sessions, the Gurukul. Thank you, Karan, for taking this up, the myeloid neoplasm drugs this time. So I think with this, Karan, should we move ahead with the questions and answers, or is there
Yes, sir,
anything?
absolutely. I
Yes.
mean, we have
So I
some
just
set.
I just felt that Stalin has already covered quite a bit of a framework within which we have to work when we use myeloid. I mean, you treat myeloid malignancies and the drugs that the way that we have to use. You have to be very judicious about the choice because we know that there are a lot of gray areas and there are a lot of surprising toxicities that emerge over here. So let's go ahead and see some of the let's discuss some of these things. Yeah, thank you.
So I think
we can have the slides here. Yes, sir. I'll just get the slides up.
And I believe Dr. Rohan and Dr. Aishwarya are there as examinees today. Welcome, Dr. Rohan and Dr. Aishwarya.
Yes, they're
Yeah.
there.
Thank you for joining our
Thank you,
Gurukul.
sir. Thank you,
Himanshi,
sir.
can we have the slides, please?
Yes, sir.
Sir, in the meanwhile, when we have the slides, maybe you can start with few questions from the clinic related to some chemotherapy, sir.
Yeah. So when we're talking about myeloid malignancies, the first thing that comes to our mind is actually acute myeloid leukemia, isn't it? And of course, chronic myeloid leukemia. So I think, yeah. So when we talk about acute myeloid leukemia, let us. Could I ask the question from both the candidates can take up the question as to what are the basic mechanism of action for cytarabine, and why do we think that we get some of those specific toxicities that are related with cytarabine, and how can you prevent that? Yeah.
So cytarabine is basically it is it inhibits the dioxycytidine kinase. So basically, it acts at the cell cycle S phase, is a cycle specific agent, and by the dicytidine kinase, it gets activated to Ara CTP, and via that, then it incorporates into DNA and inhibits the DNA. Also, it inhibits several DNA polymerases. So this is the mechanism of action at the cellular level. Cell cycle S phase, it inhibits and it 20 to 40% crosses the CSF also. So because of that, the cerebellar toxicities are there. So because of that,
you don't get cerebellar toxicity. It's a relatively rare kind of a toxicity.
rare, yes.
Yeah.
Yes.
So what are any ideas on what are the situations that you might get cerebellar toxicity, and how can we prevent that? Yeah.
Oh, sir, older age, decreased renal function, dehydration, uh, previous neurological deficits.
Yes, that's one of the key things where we always encounter high dose with high dose cytarabine is when the patient has a compromised renal function, and there is a one-on-one correlation with the onset of cerebellar toxicity, and it's primarily because of the affection. Like alcohol, it affects the Purkinje cells, and that's how the various manifestations also. So, what are the precautions that you would take over here, these patients? So, identifying the patients, elderly patients, as you rightly said, yeah, and also in terms of identifying the problem earlier, because once you develop cerebellar toxicities, then it's a strict no-no for using cytarabine, even though it's one of the cornerstone for treating acute myeloid leukemia. Yeah. Okay. So, yeah, Prashant, is there anything else that you would like to add?
Oh, I think so. You have covered everything. The only thing is that, high dose RSE was actually my thesis. I randomized 2 doses of high dose RSE in AML
Yeah.
in consolidation. So I just, it's a very versatile drug actually. So you can give it subcutaneous and has a very large dose range which you can use. So, at high doses, a very high doses, 1 gram per meter square and above, and even 500 milligram per meter square and above. So, people did try giving it as as a long infusion also, and unfortunately, it could not be given that ways, and there was considerable gut toxicity, and colitis was a predominant toxicity by using high doses with a long infusion. So it was always used later on as a short infusion when it was given at high doses. So that's what is I came to know when I was doing my literature review for my thesis. So but it's a very versatile drug, and it can be used in various different ways, various doses, infusions, and short infusion. And for cerebellar toxicity, you already explained that it's a rare toxicity, and we generally still do cerebellar function tests after every dose, and every day we monitor these patients.
Yes.
Generally,
So
most of
that
these toxicities which I've seen, no, I now I get to see less of those toxicity, probably because you're using intermediate doses
yeah.
and not so 3 gram per meter square. We are not using a lot. The doses in high dose RSE consolidation have also changed over time in the last 10 12 years probably, and probably we are more careful also. And but still, most of these toxicities which I saw during that time, they used to reverse spontaneously, most of those, once the drug was withheld for a
Yeah.
few
So
weeks.
that's a very important point that we sometimes take it for granted. So all of our patients who are on that it should be the morning rounds, to check whether there is any subtle features, because once they
Right.
become fully manifest, then they are irreversible. So intervention is to stop the medicines at the earliest sign of occurrence of cerebellar toxicity. Um, yeah. So
Think so.
thanks.
So I think
So,
there is a question on the screen now. This
yeah.
is a patient with AML post-transplant, and you see this peculiar, rash on the hands and feet. And then, let me ask our examinees, what is this about? And there's some few questions on the screen. And Dr. Rohan and Dr. Aishwarya, you can take up these questions and answer each one of those. What do you see here? What's going on?
Uh, Looks like HFS, sir. The drug probably causing this is gilteritinib. Mechanism of action FLT3 inhibitor. Trial for maintenance post-transplant was Morpho trial, sir. And other drugs in the maintenance setting, I don't know how effective, but midostaurin, I've seen it used. Sorafenib, I've seen it used.
Okay. So thank you, Dr. Rohan. Dr. Aishwarya, would you like to take up this same question again? I can't hear you. Are you?
So it looks like HFS only to me also.
So what
So,
drug do you think it is?
all the FLT3 inhibitors are one of the side effects is HFS. Some other drug.
So what are they? I mean, these are all come into vogue more recently. Are there
Ruxolitinib.
any of the other drugs that we use for treating a specific condition can cause these kind of toxicity in this
So
situation?
what is the drug with the most robust data for
Yeah.
post-allo maintenance? Let me ask this way. The most robust data, randomized data in all comers, irrespective of the mutation status.
Venetoclax, sir.
As I
Okay.
say, no.
So let's move to the next slide and let's see the answers now. It's going to be very interesting. So this is hand-foot syndrome. You identified correctly, but the drug implicated here was sorafenib. Type 2
Sorman trial.
Soormain study. Yes. So this is a randomized study which presents the most robust data for survival advantage in AML post allo. And in fact, this was the only study which has actually shown advantage in a randomized fashion. The rest, all of the studies, if you see, there are subset analysis, post hoc analysis, but none of the RCTs have shown such a benefit which sorafenib has shown. Gilteritinib, you're right that in the Morpho study, the post hoc analysis of those who actually had FLT3 burden before allogenic transplant, it actually benefited. That subset benefited from further maintenance with guilt, but otherwise it did not. And with midostaurin, there is hardly any benefit. And with the quizartinib, none. So none of the other FLT3 inhibitors have actually presented any robust data in post-allo maintenance apart from sorafenib. So again, coming to the same study, can you tell me what dose range of sorafenib was used in this particular indication? Also, tell me,
200 m.
is it FDA approved in this indication, sorafenib? So it is not FDA approved, but it is there in somewhere in the guidelines somewhere, and there is robust data to it, but not FDA approved for this. Is off label.
So, any reason why the Soramin study has not become standard of care for these patients? Still, even though there is there is a survival benefit
RFS,
or a progressive
RFS.
survival benefit. Yeah.
And I think the
Probably
two-year
because of
PFS,
toxicity, sir.
yeah.
Basically, because of the toxicity. The toxicity is very profound. In fact, if you look at the data, hardly any patients even could complete the planned 6 months of therapy over here. So, so the next thing that has happened is with gilteritinib, and with gilteritinib, as Dr. Prashant rightly said, uh, who do you have any comments upon who would you pick and choose to give gilteritinib as a maintenance therapy? Of course, they have to be FLT3 mutated, but it's just a question as to whether you have read the article on this.
Probably for patients who are gilteritinib MRD positive prior to transplant, sir.
Yes, so that's the
Yeah.
right. So it didn't show any impact in patients who were MRD negative, and there was only benefit for those patients who were MRD positive, and that too again for a limited period of time. For 6 months, it was given. But the important thing is, uh, it's still not ready for real-time use because the assays to identify FLT3 MRD positivities are still not robust enough for us to be taking decisions based on that. That's the only thing. So, based on the Morpho study, you may still end up giving a short course of gilteritinib as a maintenance therapy, primarily because the assays that we require to ascertain truly whether it's MRD negative or positive are not robust yet. Okay, so
I think with that, with those wise words, we can move to the next question. So this is the probably the Morpho study, where there was some benefit in those who had FLT3 burden before allogenic transplant with using some gilteritinib. So I think you can move to the next slide. So this is a patient with APML, 35-year-old. So there is a characteristic ECG change here, which you can see, and you can tell me what could be the causative agent for this, and what should you check for in the patient in terms of, let's say, the labs and the clinics, and name any other drugs used in AML which can cause the same problem, and which other FLT3 inhibitor does the same via a different pathway. So I think one of you can take the question. Dr. Rohan, would you like to start?
ATO, sir. What you should check for the patient is probably hypomagnesemia. Other drugs can cause this. Again, inhibitors mostly, sir.
What change in the
And
ECG notice?
sir,
What change in
there
the
is
ECG do you
there is a
notice?
There is a QT prolongation shot, sir, with uh, there is a T wave inversion in almost all the leads.
Okay. So other drugs which cause the same problem in
Um,
a
in AML, I'm aware of only the FLT3 inhibitors, sir.
okay. So Dr. Aishwarya, the next question for you. Which other FLT3 does the same via the slow delayed rectifier current? So all the FLT3 inhibitors, they actually manipulate the rapid delayed rectifier current, but there is one which doesn't, which actually works through the slow delayed rectifier current. That's why the QTC prolongation is unpredictable. And even the QTC prolongation cannot tell you what is the risk of arrhythmia or sudden cardiac event. What is that drug which is more dangerous with this in this regard?
Midostaurin.
Okay, let's move to the next slide. There'll be answers there. I think move the slide. Mhm. So the causative agent here in this particular indication is ATO. So arsenic causing QTC prolongation. What should you check? Potassium and magnesium. Both should be kept in range so that this problem doesn't happen and can be avoided and the toxicity is reduced. The other drugs which can cause the same problem, you were right. Other FLT3 inhibitors and also to an extent hedgehog inhibition, glasdegib. But glasdegib in the real world studies and the post hoc data is showing very minimal effect on QTC and it's rather safer in that regard. Revimenib and then this all these actually do the same by inhibiting rapid delayed rectifier current, which is IKS. But the quizartinib it does the same by slowing down the slow delayed rectifier current. So the above one is actually IKR. It should be corrected. Quizartinib does it by IKS. So this actually is the mechanism by which quizartinib does the same, and it is more unpredictable. So you have to be much more careful with sudden cardiac events, even with normal QTC or very minimal prolongation. It can actually be uh, a problematic drug, and that's there in the package insert of quizartinib also. So next question.
So can I just about
Yes, sir.
the
Please.
previous? So what are the basic precautions that we would want to do when we treat APML patients? When we
One of our
treat APML
examinees
patients,
can take that question. Dr.
Sir,
Aishwarya, would you like to answer that?
this is because it's from the perspective of treatment. You
Um,
said you said QTC prolongations. What are you looking for in these patients? What causes sudden death? QT, or not all QTC prolongation cause sudden death, but what is it? What is the thing that needs to be picked up on an ECG, which besides the PTC, which will actually lead to sudden death?
Torsa, the pointers.
That's right. So you need to look at TOSA. TOSAs can cause sudden death, and it was first identified with ATRA in patients, and it is a blood publication also as a case series of 3 patients who developed TOSAs. And one of the ways to also avoid QTC prolongation or identify QTC prolongation is to ensure that there is no dyselectrolytemia, particularly hypokalemia and hypomagnesemia. So that's very important when we treat, and that's why we are liberal in doing ECGs when patients are doing, and at least a minimum of twice a week when these patients are, and also monitoring the electrolytes on a regular basis. We generally don't do magnesium levels, but we give magnesium supplementation because unless you give magnesium supplementations, then potassium correction can never take place, and so you'll have persistent hypokalemia, which will again increase the chances of QTC prolongation, which can be problematic. Yeah, so that's just a point that you need to keep in mind when you are treating APML patients.
Beautifully.
It's an avoidable mortality, isn't it? So that needs to be careful. Yeah.
So, that brings me to the hyperleukocytosis issue also. So, how do you control the leukocyte count at the outset? Dr. Aishwarya and Dr. Rohan, what strategies do you use in APML, which is able to prevent the differentiation syndrome, hyperleukocytosis, and all the manifestations thereafter? Is there
Along with the induction, can add mitochondrion.
steps you can take?
The induction, we can add anthracycline, sir.
Okay, that's one way. Adding chemotherapy. Do you do something for the high intermediate risk? Do you add something, some drug, which you also use for therapy, which was given in this particular case, in the last case? Any role of prophylactic steroids? Do you add that?
Yes, sir.
Yes.
So prophylactic steroids can be used. And does
To prevent the differentiation syndrome, yes.
It's all again not about
Yes.
prevention, it is about anticipating. You anticipate that this is a possibility that will have, and you take preventive action for that.
Yeah.
So when you
So
look at the trend, you look at the trend of the leukocytosis, and if there is a rapid doubling of those leukocytes, then it's very likely that it is the differentiation syndrome is biting at the heels, and you're likely to develop. So you preemptively look at treating these patients, and if it is early in the phase of the treatment, we have to be also careful about using. It's easy to use anthracyclines over there, but we should also keep in mind that in the early phase, usually in the first 5 days or so, when we treat with anthracyclines, easy to give anthracyclines, but we should also keep in mind the onset of DIC, which is precipitated by the administration of chemotherapy over there. Yeah. Traditionally, we use mitochondrion in these patients, but
and also
nowadays we use.
with the advent of Atra ATO, so it
Yeah,
has become a common practice now to start with ATO.
yeah,
So and that
correct.
can also reduce the problems later. And also uh, high dose hydroxyurea is what has been has become kind of common, and that some people call it the Toronto protocol, and some of the data which has come from CMC, and they have used probably the escalating doses of hydroxyurea looking at the white cell count, and that has also become common in our country. It's a resource saving intervention which can actually prevent problems and high leukocytosis and the consequent problems during atra ATO administration. So do you have any thoughts on that high dose hydroxyurea protocol? We have been using it, and
It's just
we
that
found it very, very
we
safe
can
and effective.
we are. It's an effective protocol, but then there is also the problem of the patient being able to take this, because many a time hydroxyurea and higher doses are not so well tolerated by the patient, and the patients are quite sick. But to me, hydroxyurea is probably safer in the early phases of the treatment, but you get more dramatic results when we use an anthracycline over there in patients, because. But it's all about not wanting to use the highest doses, because APL cells are exquisitely sensitive to anthracyclines, and I just wanted to ask it, why do you think that APL cells are exquisitely sensitive to anthracyclines? Is there any reason for that, or is it just a finding?
Don't know, sir.
Yeah. So there is a feeling that their drug resistance levels in these lines of cells are much lesser as against the thing. That's why they started using idarubicin as part of the main protocol. And what is the unique feature of idarubicin which goes over other anthracycline, donomycin, and adriamycin? Do you have any thoughts on that? As to why is idarubicin considered a little bit superior to donomycin? And that's why it's in
Safety profile, sir?
all the no, it has got, in fact, it's got higher incidence of GI toxicity. Yeah.
Don't know, sir.
So basically, they are not governed by the P glycoprotein. Yeah. So idarubicin is not dependent on the P glycoprotein. So for its extrusion, so it allows for its higher concentration in the cell. So um, that is one of the mechanism of resistance also in myeloid neoplasia, myeloid neoplasms. So that is one of the reasons. So that's why if you look at the protocols, all of them have idarubicin and not tonomycin, especially from the Italian group.
Yeah.
So can we go? We'll go to the next question. Yeah.
I think, yeah. So this, you will have to go back to the previous slide, I think you. So this drug is very, well known, actually, blue colored drug. Can you tell me the name of the drug, one of the examinees, and which class does it belong to? And what is the cumulative cardiotoxic dose of this drug?
Mitoxantrone, it's an
Mitoxan.
anthracycline.
Both of you are correct. So yeah. So I think go to the next slide. The cumulative cardiotoxic dose, Dr. Rohan?
More than 140 to 150, sir.
Okay, fine.
What's the
Go to the
normal
next slide.
dose that we use for mitochondrion? And what is the normal dose that, how is it different from when we use it with lymphomas as against using it in as part of the salvage regimens and what are the specific issues that we tend to come across in mitochondrion? And while we are discussing actually the myeloid neoplasias, where has mitochondrion really scored in treatment of acute leukemias? I'll give you a clue also about it's mainly in the pediatric population.
Not sure, sir.
So
Dose,
yeah. How is it used in the mind regimen? How is
no idea,
mitochondrion
sir.
used in mind regimen? Because I don't think you people use mind these days. That's why. Yeah? Yeah.
Sir.
So one caution that we have to think many a time, at least when we were thinking is that as against the mind regimen where you use it for 3 consecutive days, here we don't use it for 3 consecutive days. Yeah. So the other way, if you by some chance if you shall use it, your toxicities are going to go up. GI toxicities and bone marrow suppressions are far more profound with the with the mind regimen. So as against sometimes the recovery that we would anticipate in somewhere between 3 to 4 weeks of the bone marrow, it might go up to as many as 6 weeks in these patients. Yeah. Yeah. So go ahead. Yeah. They just
The
need
other
to.
question is also very interesting. I think you should answer that. What pediatric indication mitoxantrone actually scores over other drugs? There's a particular indication there, and there is a particular benefit. At relapse, actually, I can give you a clue. Rohan, Dr. Aishwarya, any answers to that?
Sorry, I had to take a call. So, yeah. So, did you have an idea? Yeah. It is an NEJM publication, and one of the Indian authors, Dr. Vaskar Saha, is one of the key, and it was one of the where mitochondrial scored. It is basically one of the components of salvage protocols for relapsed acute lymphatic leukemias. Yeah.
It's the UKLLR3.
Yeah.
Yeah, where it actually was there was benefit over and above any other anthracycline, and in fact, in this case, probably over Dono. So, the cumulative cardiotoxic dose, 200 milligram per meter square, as per our answer, but I think it is in that dose range. So next slide, I think you can move to the next question. Next question. You can move to the next slide. Yeah. So this is the fourth question, like 63-year-old male AML patient with 54,000 count and 90% blast started on treatment. Day 3 presents with dyspnea, desaturation, hypotension. So what could be the differential diagnosis? You will need to slightly move this, slides, because I think there is an image alongside this slide, which will only show up if you move. Are you getting my voice?
Yeah. Yeah.
So this image will be required to for them to make a differential diagnosis.
Differentiation syndrome, sir.
Okay, that's one of the differential diagnosis. Okay, so I think you can move ahead.
So where I just asked, where do you,
Hyperglucose.
yeah.
So
So
Glucostasis, also
okay,
fluid overload,
okay,
infection.
okay,
Infections.
yeah, so that's true. But this is a very florid kind of picture that is there over here. Where do you actually, for a discerning, if you want to really look in a discerning fashion, because again, as I said, picking up these earlier is more important than treating the manifest symptoms, isn't it? So where are the, when you do an X-ray, where do you look for the earliest features of differentiation syndrome that is manifest on an X-ray?
The costochondral angles, sir.
Yeah. So what do you see over there? It should be a
You
good
see a
X-ray, of course. Not
blunting of the costocost.
Actually, if you look carefully, you can see linear markings that are happening, and that is because of the interstitial collection of the fluid that is there, and that's probably one of the earliest. And of course, the patient has symptoms related to interstitial, I mean, edema in the lung, and which is manifested by stiffening of the lung and difficulty, and a sense of feeling that the patient that he can't breathe enough in these situations. So these are the small things that one would like to pick up early in patients as matter of rather than this. This is a very florid picture. And what are the differential diagnoses over here? Okay, differentiation, sir, but what are the other differential diagnoses over here?
Glucostasis, fluid overload from IV fluid, cardiac failure.
Cardiac failure, would it be like this? No, I would disagree. Yeah. Something else.
ARDS.
Infection, yes, that is. But you see that these are all fluffy shadows that are there, and all in the bilateral lung field, and you're having it extending right from the periphery uniformly into the center. So where do you get that kind of a pattern? And you have acute promyelocytic leukemia, and the patient's saturations are normal.
Leukostasis.
Basically, alveolar hemorrhage, no? Alveolar hemorrhage will manifest like this, isn't it? Yeah. Alveolar hemorrhage will manifest like this, yeah. But of course, the patient will be quite sick. But again, if you look at the saturations, they may be all normal. Yeah. So,
but our examinees in the chat box have already answered it.
yeah. Okay.
Good.
Okay. Yeah, I did see that. Sorry.
Yeah. So great. So I think show the next question in this slide only. You move ahead. Go back. No, you're moving too fast now. Go back. Yeah, go back one more. Yeah. So if sepsis, infection, alveolar hemorrhage has been ruled out, what could be the possible diagnosis? And name the drugs which could be actually implicated in this situation. Now you can move ahead. Let's say I tell you this patient had an IDH mutation and he has been on a well targeted drug. Now would you change answer in any way?
Yes,
I
sir.
will see that.
Differentiation syndrome.
Okay, fine. So move to the next
I
slide.
will see then.
Okay. Go move ahead. Next slide. So IDH inhibitors can cause, and this patient actually had all these DDs were true, and alveolar hemorrhage also, very important DD. Should be mindful of that. And all these drugs can cause this syndrome, and dexamethasone is the treatment. So I think next slide. So this is a patient with, go back to, question 5. So anemia, thrombocytopenia, 63-year-old male, lymphadenopathy, skin lesions. And this is the characteristic flow cytometry finding. CD1 to 23, CD4, CD5, 56 positive cells. What is the diagnosis now? It's like a spotter.
So the answer was
It's
BPDCL.
yeah, absolutely. It's already there in the chat box. Our examinees are too fast. So the treatment, anybody?
Agraxopus.
Yes. Complication? Spotter. Next slide.
Don't know, sir.
Which interleukin does it contain? Itagraxofusp. And which drug? Which toxin?
Do you have any idea what kind of a class of medicine this is actually? Diagnosis. What class of medicine is it? It's an yeah.
It's a toxin. It's an immunotoxin.
It's an immunotoxin. That's the answer.
Yes.
So it's an immunotoxin, and what toxin is there? Usually, that's a very common thing that we always use. I mean, in most of the immunotoxins, diphtheria toxin, isn't it? Yeah. Okay. Yeah. So
all answers there.
Prashant said IL-3. So what does it manifest when IL-3 is high and any of these cytokines are high? What does it manifest with?
CRS. No. Capillary leak.
Capillary leak. So any other cytokine where capillary leak syndrome is a predominant manifestation, any of the more, since we are talking about a rare condition like the DTCDN over here, any other rare condition where it is also referred to as a specific with a specific cytokine syndrome called the IL-6 syndrome. What is the IL-6 syndromes?
Don't know, sir.
So that's usually the disease that we usually come at IL-6. Castleman's disease is one of them, and the Castleman's disease is usually manifest with capillary leak syndrome, and that's primarily induced by the high IL-6 levels that are there. And any idea about where now IL-6 has come into every aspect of our investigation repertoire?
CAR-T also, sir.
Pardon me?
CAR-T.
Post-CAR-T.
Yeah, post-CAR-T cell, yes. So that's why they say that one of the triggers is considered as for the CRS is the IL-6, high IL-6 levels, and that's a marker for, okay. So
next slide.
Digressing from myeloid leukemia, yeah, okay.
Admin, next slide. Yeah, so all these answers already being given. Next slide. So now what is this movement going on? What is this sign? What is the problem the patient has? AML patient on treatment, name the drug associated. Already we have had a discussion on this. How do you treat this and what are the other complications of this drug? Dr. Rohan, Dr. Aishwarya.
Problem is cerebellar toxicity. Drug is cytarabine. Treating will be immediately stopping, hydrating, and supportive care.
Okay.
And other complications is this conjunctivitis, keratitis, GI toxicity, cytopenias.
Okay. I think move to the next slide. What is this sign called? It's on your screen now.
It's on it. It's
Lidocaine.
Okay. So hydrocytarabine stop the HIDAC. There's some anecdotal reports of using steroids also with this, chemical conjunctivitis rash and all the cytopenias and all are the other toxicities. Move to the next slide. 23-year-old male AML, 95% blast, counts 89,000, fungal pneumonia on presentation, treated with less intense therapy. On day 2 of treatment, he complains of palpitations and muscle cramps. What problem could be going on here? Dr. Rohan and Dr. Aishwarya. So I'm watching the chat.
Venetoclax causing
Yeah.
TLS.
Yeah, absolutely. Next slide. Next slide. So, what is this anomaly you see in the ECG? What issue is there?
Salt-tinted T waves,
Yeah,
hyperkalemia.
absolutely.
Hyperkalemia.
What electrolyte disturbance? Tall T waves effect?
Hyperkalemia.
Yeah, absolutely. So, what other anomalies are anticipated? Lab abnormalities are anticipated in this.
Hyperuricemia, hypocalcemia,
Hyperkalemia.
raised creatinine, hypocalcemia.
Hyperphosphatemia.
Yes, absolutely. So, what is the implicated drug here? You already told that, okay. And how do you prevent this problem?
Prehydration,
Okay,
step-up
TLS
dosing of
profile
venetoclax.
accessible.
Flaxes, okay,
And for venetoclax, step-up dosing, sir.
okay.
Uh,
In which other condition the ramp up where the ramp up dose is used and the TLS frequency is higher with venetoclax? More problematic.
Pardon?
You see more
CLL,
TLS,
SLL, sir.
which other indication where venetoclax is used?
Basically, he mentioned that it's in chronic
Yeah.
lymphatic leukemia, and yeah.
So, what drug do you use to prevent hyperuricemia and AKI?
It's on the screen, sir. Raspberry Kit.
Already on the screen, okay. What blood test do you order when you see a patient who may develop TLS or has TLS? When you want to use raspberry case?
G6PD.
Uric acid, renal function.
Okay. So next slide, I think.
So when you are having,
Six PDs.
so while I'm just looking at basics over here. So when you are anticipating a patient to develop, uh, um, you have certain criteria of patients, categories of patients who might develop tumolysis. So, would you, what is going to be your strategy to actually be prepared for something like this? And what are the disadvantage of starting allopurinol as a frontline therapy? I mean, as to this thing, do you expect benefit from allopurinol in these situations? So my question is, how do you effectively use allopurinol or febuxostat for that matter?
Sir, in the frontline setting, allopurinol, we won't expect to benefit because it takes
Why?
time to act.
So why is that? Why is that reason? What do you have an idea about the mechanism why that has happened? Because everything is about, as I told you in the beginning of when I just commented, you need to know the mechanism of how the drugs work, because then you are able to implement it in the appropriate fashion. So do you have any thoughts on that?
It's allopurinol is a xanthine oxidase inhibitor, so it inhibits the formation of uric acid, but it won't deal with the uric acid that's already been generated, sir.
Correct. So that's the reason. So the uric acid levels, especially if they are very high, or then it is better to treat them upfront with. You can use simultaneously start with, but its effects are probably seen only after about maybe at the end of 1 week or so, because it doesn't prevent. It doesn't have any impact on the existing uric acid. It only prevents the further formation of the uric acid. Yeah. So that's a good point. Yeah. Thank you. Then.
Great.
Yeah, let's
So
go
this
ahead.
is the Cairo Bishop definition of lab TLS on the screen. Next slide. 37-year-old male with CML lymphoid blast crisis treated with hyper-CVAD dasatinib and not willing for allo. Had CNS relapse. Marrow was in CR but did not get an allo. And patient was in dasatinib steroids and he had subsequently a relapse. In this slide, I think it mentioned as testicular relapse, but let me change that to a marrow relapse. So move to the next slide. Next slide. Yeah, after 6 months, he has a marrow relapse. Any specific testing would you like to do at this point in time? What drugs are useful for this, particular mutation or alteration which you find on this test? And what is the dose and what are the complications?
The test I'd like to do is an IRMA.
Okay.
That is the TKD mutation analysis. Look for a
Okay.
T315I.
Okay.
The drugs. Dr. Aishwarya, you want to take this?
No, you can.
Oh, sorry. The drugs will be ponatinib and asciminib.
Right. So
The
what doses
complications, ponatinib, the dose 45 mg, but that is then asciminib for the T315I is a higher dose, 200 mg.
One.
what is the tablet strength of asciminib?
50 mg tablets. No,
The 40 mg tablet.
40 mg tablets. Sir.
Yeah. So what are the problems you see with ponatinib? Go back. Complication. Ponatinib, what issues you see?
Vaso-occlusive disease and pancreatitis.
Okay, great. So I think move to the next slide now.
So this just a point I mean, you need to do the mutation analysis, all right, but it is mandated that any patient who has been identified as Ph positive ALL or patient in blast crisis, that you do the upfront mutation analysis in this patient so that you don't want to miss a T315I mutation, because our line of management will change over here, because you're wasting time by giving many of the other TKIs if you do harbor a T315I mutation. So in these situations, you may want to look at treating it with ponatinib upfront, and also plan to take up for a transplant earlier. Though the data now for the use of ponatinib with blinatumomab is quite impressive, but I think the most important thing that one has to take away should be that all patients with Ph positive ALL or blast crisis should have their mutation analysis done upfront, which is not the case when we diagnose a newly diagnosed patient of chronic myeloid leukemia.
So I think let's move to the next slide. This is a standard risk AML attained CR, but was MRD positive following induction and taken up for allo. So on day 17 of MAC conditioning allo, he had weight gain, ascites, right hypochondrial pain. So what could be this problem? Dr. Rohan and Dr. Aishwarya and all those in the chat box. The chat box is doing a great job, let me tell you.
Veno-occlusive disease we should look for.
Absolutely. Correct. Great. Next slide. So what could be the possible drug in induction which could have led to this?
Busulfan.
I tell you, this is a core binding factor.
Busulfan? No, in induction. In
Induction.
In induction,
Gemtuzumab.
Geo.
Absolutely correct.
Osocomycin.
How will you treat this complication? Which drug would you like to use?
Defibrotide.
Defibrotide.
Spotter answers. Okay. Next slide. So this is the problem, veno-occlusive disease or SOS. So bilirubin more than equal to 2 before day 21 of HCT and at least 2 of the following criteria. But sometimes it can present with, one few or, different features, and still your index of suspicion should be there, and any weight gain, right hypochondrial pain, your eyes should be out, to treat this complication early and manage it accordingly. Next slide. Next. So this is the revised criteria to diagnose. You can have a look and remember this for your exams. Next. Already told. Next slide. So this is a case of polycythemia vera, and he was treated, and tell me which drug could actually lead to this problem which is there on your screen. And also tell me if this drug actually reduces the JAK2 allelic burden or does not.
Does not, sir.
Okay, does not. Okay, which drug?
Hydroxyurea.
Okay, fine. So next slide. Which drug does reduce the JAK2 allele burden?
There on the screen, sir.
Okay, already there in this. Fine, fine. So Ropac interferon decreases the JAK2 allelic burden. Okay, fine. So next slide. This is a CML-CP, and this he was started on treatment. And this has, the coronary angio has mild to moderate stenosis only in RCA, but he presented with this kind of an ECG pattern and chest pain. So what could be the problem here going on? What drug could be the offender? A commonly used TKI for
Pulmonary.
CML-CP. Okay, so the chat
Nilotinib
box is on fire.
has cardiovascular.
Okay,
So
drug and dose.
150 mg 2 BD, 300 mg
Okay,
BD,
okay,
Nilotinib.
okay. So I think let's move. Any precaution while taking this drug? How do you administer it?
Uh, empty stomach, we should
Open the neck.
administer it.
Okay, next slide.
Opposite.
See the answers
it's
here.
either 1 hour before
Yeah,
food or
absolutely.
2
2
hours
hours
after
after.
food.
Yeah,
So there's nothing like hard and fast this thing, but actually what the company doesn't say is that if you have food, you can reduce the dose actually. Yeah. So um, uh, it's just that it's a manifestation of this thing. And again, when we use nilotinib, it's all about picking and choosing the right candidate to receive that so that you can avoid this from happening because you can sometimes predict the possibility of developing peripheral vascular disease and also coronary disease in these patients. So it's important to pick and choose the kind of patients that you want to treat with a specific TKI when we choose a TKI for treating CML.
absolutely. So this problem is the myocardial infarction with non-obstructive coronary arteries or MINOCA. So next slide. What is true regarding sorafenib maintenance in AML post-halo? So this was already discussed when we discussed the SORMAIN study, but this is more specific. Does it have more skin toxicity, more cardiotoxicity and renal insufficiency, more electrolyte disturbances, more severe chronic GVHD, or all the above, or only 1 and 3?
All of the approach.
You're right. It was toxic. That's why it has not been taken up well. For 24 months as the trial criteria, and also it was started after 60 days of transplants. So between 60 and 100 days. So it would have been very tough actually. So that's why many patients were not able to complete the trial, the protocol treatment. Next slide. Next slide. So which of these drugs actually does not inhibit the FLT3 TKD out of all these four? So simply put it, you could say
Quizartinib.
type 2, which is a type 2 FLT3 inhibitor out of all
Quizartinib.
these four. Quizartinib, okay. So you correct answer. Great. So I think this was the last question, I believe, Dr. Ramesh, is that? Next slide. Yeah. So I think with that we have completed our examination, and every student, and including Dr. Rohan and Dr. Aishwarya, have done exceedingly well, and the Gurukul is
Thank you, sir.
successful. And with Hari sir's presence, we got so many wise pearls today, and all the students have immensely benefited, and we are very happy.
Just
Thank you,
a
sir.
point on while we were at Mylotag, it's a wonderful drug, and it's just a ideal example of a drug that was inappropriately brought into the market without understanding the problem. And it's a good drug, and we had to wait for almost 15 years before we could use it in these patients. So by reducing the dose and appropriately using it, we could reduce the main toxicity, which is VOD over here. And it's currently, if you look at the all the protocols, especially the UK protocols, it incorporates uh, it incorporates it into the regimen of all patients who are on the standard and intermediate risk because there is a survival benefit in these patients in terms of better PFS in these patients and better remission rates in these patients too. So that is something that needs to be looked in about how to handle a drug in the most appropriate way. Yeah.
So another example is belantamab mafodotin. So it
Yes.
was taken off, and then with Dream 7, you're finding a major advantage with using it. And now people have used it, you started using it with alternative dosing, and they have been reasonably successful. And the drug is making a comeback now with the in refractory myeloma, and it's easier to use than many of the BCMA bites and CAR-Ts. So I think there is every drug may have a place eventually if used in a particular fashion and in a more in a better fashion. So maybe many of these drugs can be used in a better way in the real world than they are in the clinical trial initially.
Yeah, I see my dear friend Lalit over there. Any final comments, Lalit? Yeah.
Yeah, Hari, thank you so much. And in fact, truly enjoyed listening. I'm in a travel, so I can't interact much with the limited network, but I'm truly enjoying the discussions and truly appreciate you and the other participants' excellent. Truly appreciate the learning. Thank you so much.
I think there are some questions on the on the webinar, this Q&A region.
Yeah.
Q&A
Yeah.
area.
Okay.
I
Okay.
think Dr. Stalin has, I think, taken up those questions. But Stalin, sir, are you there?
Are these answered already, these
A
questions?
few of them have been answered, sir. But
Okay,
I think Stalin, sir, probably.
So
I'll
we
just
can
see.
just
Nice question, actually. Some anonymous attendee has asked, do we always have to treat MPAL as ALL? Professor, would you like to answer that?
um, generally, it is easier to treat with an ALL protocol in these situations, but there is really no data to say that you treat it with one or the other. But then you look at you really look at the immuno the flow pattern over here. And if you're really looking at more of something like an ETP-ALL profile or something, because you know that something like an ETPLL is usually having the pathway of the myeloid lineage actually, and in those situations we tend to use we tend to sometimes move towards using a myeloid kind of a regimen for these patients. But at the end of the day, when you're talking about ETPLL, you're ending up using a lymphoid kind of a treatment over there, even though it's the myeloid way through which the pathogenesis of the disease happens. But at the end of the day, so then you boil down to more recently the data of using hyper CVAD over here, and it is also demonstrated that it doesn't matter what regimen that you use. It's important to get it into a remission status and preferably get into an MRD negative status. It doesn't matter how you use it, whether you use a myeloid regimen uh, or ALL-like regimen in these situations. Yeah.
So I think, adding to the flow cytometry, if you add the clinical features and genomics, that
Mm,
also sometimes can guide us.
correct.
If the
Yes.
clinical features are having a lot of lymphadenopathy and splenomegaly, and the presentation is similar to a lymphoid malignancy, then probably you would be leaning
Correct.
towards. If the
Yeah.
patient doesn't have any splenomegaly, no lymphadenopathy, and has been labeled as an MPAL on flow, and genomics also doesn't tell you much, then maybe I would be slightly inclined towards treating like AML. Would you, Professor, in that
Yeah.
case?
Yeah. 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 As I said, it doesn't matter what we want to use. It is the dose intensity also that we have to look at. So you have sufficient amount of. So sometimes I tend to skew towards using more of a lymphoid regimen because it contains many of the drugs that are effective in the myeloid lineage
Right.
also. But then one of the more, I will not say balanced. I'm not terribly fond of using the hyper CVAD regimen, but the hyper CVAD regimen balances out drugs that are useful in the lymphoid and in the myeloid kind of.
So with the data now coming up for flag when is
Yes.
showing very good
Yeah.
outcomes. So would you think of something like flag when treating MPAL upfront?
Um, uh, yes, that is something that can be considered over here. But the problem is that whenever we have used a flag itself is a very, very difficult disease, entity to with a neutropenia that can go up to about 6 weeks over there. But at the same time, even and when you're adding venetoclax, the amount of neutropenia, the bone marrow suppression is expert. That is the challenge that we are going to have over there. And at the end of the day, we have to bring out the patient too. So if you are going to, and that has been the story as far as the use of very high doses of cytarabine also has been concerned. You're not being able to bring out the patient. So while in principle, yes, it is a good drug, but whether it is implementable is a question over there. So generally, when we are having some patients, like increasingly for in ETPLL, if you look at it, they have a myeloid, and we tend to look at it more carefully. Some of them have a CD38 expression over there. So daratumumab becomes a very useful drug, and we have had a few patients whom we have looked at treating with daratumumab with a myeloid-based regimen, getting them into remission, and then taking them for transplant.
So I think with that, I think we have come to the end of this Gurukul, and I would ask Professor Dr. Hari Menon to give his closing words, closing comments, and then we can probably
So
close.
thanks, Prashant. I think it's a really nice kind of a platform for us to reach out to a large number of students. And actually, I would say that the students have to give us a feedback as to how useful it is for them. But then my treating treating with drugs of leukemia or leukemia for the matter, any oncological thing is should be considered as an art rather than just going by fixed notions that this is the way that we have to treat it because every single patient is different. And at the end of the day, I always feel that we can do harm provided we can get the patient out of it, but we should not venture into something which is very clear cut that the patient is not going to come out. So you have to balance your treatment adequately because at the end of the day, you should get them to survive also, isn't it? So, and that comes through only by understanding the drugs, the mechanism of actions of the drugs, what are the synergisms and what are the toxicities that are induced by combination of the drugs, even how they have to be timed. Many times for convenience, one might look at using using schedules that may not be appropriate, which may add to the toxicity. So you need to understand how to schedule the drug also. For example, when you're using the CLAG regimen, for example, over here, you need to schedule the drug. Otherwise, the entire regimen falls flat, isn't it? So, and that the CLAG regimen, for example, goes on the premise that cladribine increases the levels of cytarabine. So if you give cytarabine before cladribine, then so you need to have that understanding. So I would encourage all the students to actually spend time to understand the drug very well. Then you are able to manage the toxicity, and everything is about anticipating problems. It is not about treating problems, actually. Yeah.
Completely. So with that, I think we will close this session. Thank you, Karan. Thank you, all the students, all examinees, and all the faculty who have contributed to the Gurukul. Thank you so much. Bye.
Thank you, sir. Thank you so much. Firstly, I will just tell that Dr. Rohan has won the second prize at the ISBMT poster competition, and he is at the ISBMT and he's giving the examination from there. Also, Dr. Aishwarya is alone today. Her colleague has gone to ISBMT. So, both the examinees have been very supportive. And I would like to congratulate Dr. Ramesh, who's done an excellent job in creating the questions. And Dr. Hari Menon sir, I met last week at a conference, and he graciously agreed, and he was very enthusiastic to be a part of our series. And lastly, Prashant sir, you've been a mentor, and I think this session could not have been without you. And a lot of students were actually waiting to interact with you, listen to you, and we've had an excellent session. So Thank you all. Thank you so much for joining. And I will introduce to our audience to the next session that we have on hematopoietic stem cell transplant. And we have a phenomenal team where we have Dr. Naveen Khatri sir as our examiner, Dr. Rakesh Reddy Boya sir as our moderator. Our subject mentor is Dr. Stalin. And our speaker is Shashwat Saha, who's also a student of Dr. Naveen Khatri sir. So I request you all to join us next week, this time, and we'll discuss this into the depths. So thank you so much. Thank you so much for joining. We'll end the webinar now.
Thank you.